Hi guys, so today we'll be talking about neonatal jaundice. This presentation will be divided into three parts so that we can discuss each of the components of jaundice in details, as it's very common clinically as well as in exam settings. So we'll start off with the physiology of bilirubin. So where does bilirubin come from? The main source of bilirubin is from catabolism of the circulating hemoglobin, which will get broken down by the reticuloendothelial system. So 1 gram of hemoglobin produces 35 milligrams of bilirubin, and a minor source of bilirubin is shunt bilirubin, which comes from breakdown of non-RBC heme pigments and lysis of precursor cells in the bone marrow. So how does the process exactly go? When red blood cells have completed their lifespan and they have become fragile, their cell membrane will rupture. This will release the hemoglobin molecules, which will get phagocytosed by tissue macrophages and broken down to produce heme and globin separately. The heme ring will be split into free iron and pyrrole nuclei, and this pyrrole tetrapyrrole ring is the main source of bilirubin formation. So this is a picture illustrating what we have just discussed. So you can see that the macrophage is breaking down the hemoglobin into heme and globin, and with the porphyrin ring we are getting into the or the tetrapyrrole ring, we are getting towards the bilirubin pathway, whereas the iron will either get released to transferrin in the serum, or it will get stored or added to proteins. So the first substrate to be formed is biliverdin, which will get converted to free bilirubin, which is also known as unconjugated bilirubin. And this unconjugated bilirubin will immediately combine with plasma albumin. So this is an important point to remember, that the first substrate is biliverdin. It might come up in MCQs, but this will get reduced to free bilirubin, also known as unconjugated bilirubin. And what is the main component to which unconjugated bilirubin binds? It is plasma albumin. Now in the liver, the unconjugated bilirubin will be released from the albumin, and the enzyme glucuronyl transferase will conjugate it with glucuronic acid to form conjugated bilirubin. Again, this is a very critical point, because when you see, a lot of the diseases will be arising from issues at different points of this step. So how does unconjugated bilirubin get conjugated, and where does it happen? Happens in the liver. What is responsible for conjugation of bilirubin? It is the enzyme glucuronyl transferase, and it conjugates the unconjugated bilirubin with glucuronic acid, creating the conjugated bilirubin. Now from the liver, where does the conjugated bilirubin go? It goes to the intestine, where most of it will be converted to urobilinogen. So urobilinogen, as the name suggests, goes towards the urine, and some will be excreted in the stool as stercobilinogen. Urobilinogen will also undergo enterohepatic circulation, in which 5% will be sent to the kidney for excretion in the urine. After exposure to air, the urobilinogen will be oxidized to urobilin and stercobilinogen to stercobilin. So both of these components are responsible for the normal color of urine and stool. Let's recap now. This picture is a pretty good summary of the bilirubin pathway. Now we start off with the breakdown of hemoglobin and other heme products to give us the free or unconjugated bilirubin, which will soon get strongly bound to albumin. The albumin will take it to the liver, where it will undergo conjugation with glucuronyl transferase enzyme. From there, in the bile, the conjugated bilirubin will get excreted into the intestine. Now in the intestine, there are two options. Either it will undergo enterohepatic circulation, or it will get excreted out. So in the excretion pathway, we have urobilinogen, which will go to the kidney and get excreted via the urine and converted to urobilin on oxidation, which gives the urine its yellow color, and or via the stool into stercobilinogen, which gets converted into stercobilin, giving stool its brown color. Then the interesting part is that part of this conjugated bilirubin and the bile will also undergo enterohepatic circulation. So why does enterohepatic circulation take place, or why is it necessary? The reason is that enterohepatic recycling is physiologically important for the bile salt and the bile acid, because the liver is not able to synthesize enough bile salts for for its daily needs, which are to basically digest the lipid portion of a meal. So we need to reuse the bile salts and bile acids that we have in order to digest lipids properly, as the liver is not able to make enough for its daily requirements. So what are the properties again? Now, for unconjugated bilirubin, it's also known as indirect bilirubin. It is lipid soluble. It is safe only if it's bound to albumin in the plasma. If it's unbound, the free unconjugated bilirubin can cross the blood-brain barrier. And what are the components which make this unbinding to the albumin more common? Certain drugs, sepsis, and prematurity. So what happens if the unconjugated bilirubin crosses the blood-brain barrier? It will go and affect the brain and create brain damage, which produces a condition called kernicterus, which we will talk about towards the end of this presentation. Coming to conjugated, so conjugated is also known as direct bilirubin, and it is water soluble. So you can remember it as the conjugated bilirubin is at the later stage of the pathway. It's water soluble and it's getting excreted out in the pee. So that can help you remember that. Whereas the unconjugated is the dangerous one because it's lipid soluble. You can say that it's like oily or slippery. It can slip into the baby's brain. So this question is actually very commonly asked in exams, and it's important to know. So conjugated bilirubin is excreted, as we mentioned, by the biliary system and then the kidney. And it's dangerous if if the conjugated bilirubin is high, on its own the bilirubin is not dangerous. But you need to find the cause of the elevation. So if you have a patient with high conjugated bilirubin, you will be worried because you want to know why that bilirubin is high. Let's say there's any number of problems which we'll be discussing later on. Whereas when you have a patient with high unconjugated bilirubin, you are worried for two reasons. The main reason you are worried is because this high unconjugated or free bilirubin can cross the blood-brain barrier and create a condition called kernicterus. And you are secondly worried because you want to find the cause of this high unconjugated bilirubin. So now let's talk about jaundice. So what is jaundice? Jaundice is yellowish discoloration of the skin and the mucous membranes. It starts from the head and then spreads to the feet, which means that it has a cephalocaudal pattern. If the patient is having clinical jaundice, this means that the total bilirubin is at least 5 milligrams per deciliter. We can see in this picture on the right that there is something called a modified Kramer scale. So this is a clinical method by which you can get a rough estimate of the baby's serum bilirubin level. Of course, we are not relying on this to diagnose a baby with jaundice or base our treatment off of this, but it's a good rule of thumb or bedside trick, you can say, which you can use to have a general idea. So you can see that as we're going from the head down to the toe, the anticipated level of bilirubin is going higher. But clinically, how do we measure the bilirubin? There is something called a transcutaneous bilirubinometer, which we will see a picture of in the next slide. You're using it in babies older than a gestational age of 35 weeks, or if the age is more than 24 hours. But if you're not having a transcutaneous level and the baby's preterm, earlier than 35 weeks, or still younger than 24 hours of life, then you will use the serum measurement. And of course, you will use the serum level if the transcutaneous level is elevated. So the transcutaneous, you can say, is a kind of screening in an appropriate circumstance, but the treatment and your decision making is based off of the serum bilirubin level. You can see here the transcutaneous bilirubinometer. They are using it over the bony prominence like the sternum or the forehead of the baby. And of course, we're not using a standard or fixed value for all kids. There is a graph which you have to follow for both the serum and the transcutaneous bilirubinometer. Both graphs are separate, of course. So it depends on the baby's gestational age, the postnatal age, and the serum bilirubin. So you will be able to plot them on the chart and see whether the level is crossing the normal percentile or not. So finally, coming to the types of jaundice. So we have physiological and non-physiological. And you can say that this is one of the key components which every pediatrician, resident, student should understand, because this will differentiate from a normal condition as opposed to a condition which should raise some alarm bells and which requires close monitoring. What are the features of physiological jaundice, or when can we say that a baby has physiological jaundice? This is also known as icterus neonatorum. Why does it happen? Because to summarize everything, it's because the baby's liver is still immature. So when the baby was in utero or a fetus, so the fetal bilirubin used to cross the placenta and get metabolized and excreted by the mother's system. But when the baby is born, the liver is still immature, the enzymes are still immature. It might not be able to conjugate enough bilirubin for excretion of bile. So it's still learning, it's still a bit slower than how it should be. But physiological jaundice can only be diagnosed after you have excluded the non-physiological or the pathological causes of jaundice. Now, as we mentioned that there are other pathophysiologies as well. The main one is, or one of the key ones is what we have mentioned regarding an immature neonatal liver. We have another point as well, which is that bilirubin production is elevated at that stage of life, because as you know that the neonate has a much higher hemoglobin as compared to an adult or an older child. So hemoglobin F, or the fetal erythrocytes, will be getting broken down at that stage. They have a shorter lifespan than the normal hemoglobin, so they are getting broken down more, and so the unconjugated bilirubin level is high. So the liver, again, it's already immature or slow, and it has a much higher rate of conjugation which requires to be going on. So both these components together can explain why physiological jaundice takes place. So physiological jaundice is always indirect. It will not be direct hyperbilirubinemia, because if you just keep the pathophysiology in your mind, why does physiological jaundice happen? So if you recall the pathway, you will be able to remember that it can only be indirect hyperbilirubinemia and not the direct side. It will happen after the first 24 hours of life. This is again should be engraved in your mind, that jaundice in the first 24 hours of life is not normal. Indirect bilirubin will usually reach a maximum level of 12 on day 3 of term infants, or 15 on day 5 of preterm infants. You don't need to memorize this number, but you can expect that generally within the first week of life the bilirubin peaks and then it will come down in physiological jaundice. And if the baby is breastfed, the the peak of the bilirubin can be slightly higher for reasons that we will discuss in the coming slides. Now, non-physiological jaundice, and this is the jaundice which we need to have extensive an extensive grasp on because there's a lot of components, and as a doctor, we need to know what to look out for. So, what are the features of non-physiologic jaundice? So, the onset will be within the first 24 hours of life or beyond the first 2 weeks of life. So, either it starts very early or it develops or persists beyond 2 weeks of life or 21 days of life in a preterm baby. If the physical examination reveals hepatosplenomegaly, that is definitely not normal. If the rate of rise of bilirubin is faster than 0.5 milligram per deciliter per hour, that is not normal because it shows that there is an active process going on inside the body which is causing this bilirubin to break down very fast, and it can, of course, become dangerous. Any direct hyperbilirubinemia is abnormal, it is not physiological, but we say that a fraction greater than 1.5 milligram per deciliter. If the peak bilirubin is higher than 95th percentile for age when you are plotting it on the graph, and if there is presence of concurrent anemia. So let's talk about the causes. We can divide it into two sections, the time of onset and the type of bilirubin. So jaundice starting at the first 24 hours of life, this needs to be memorized very, very well. And a huge chunk of the exam comes from this category of jaundice. So if a baby less than 24 hours of age is having a high level of jaundice, this can be because of congenital infection or because of a hemolytic disorder. Now, the hemolytic disorder can be either Rh incompatibility, ABO incompatibility, G6PD deficiency, or a membrane issue like spherocytosis or pyruvate kinase deficiency. And then when we come to the time period of 24 hours to 2 weeks of age, here we can entertain the possibility of physiological jaundice, and still the causes within the first 24 hours of age can be responsible, like infection, hemolysis, and other conditions such as breast milk jaundice, which we'll all discuss in the coming slides. And of course, jaundice beyond 2 weeks of age is another story. Here you will it will come under the category of prolonged jaundice. So you can remember the H's for prolonged jaundice: hypothyroidism, hemolytic anemia, and high gastrointestinal tract obstruction like pyloric stenosis. And then you can, of course, always add on infection or physiological and breast milk jaundice. When it comes to conjugated, usually it presents at this stage, which is older than 2 weeks of age, in which you will find conditions like bile duct obstruction and neonatal hepatitis. So this is, like we have mentioned, the causes of prolonged jaundice. You will have different causes for unconjugated and conjugated. So we'll talk about each of these conditions in details in the coming presentation. But the most important take-home messages from this presentation were to remember the basic physiology of bilirubin, because if you remember that, A, you'll be able to answer many of the exam questions, and B, when we come to talking about the diseases, it will be much easier to understand and remember why each of them causes jaundice. The second point you have to remember is the types of bilirubin, unconjugated and conjugated, why unconjugated bilirubin is very dangerous, and secondly or thirdly, what the red flags are for non-physiological jaundice, or how we can safely classify a patient as having physiological jaundice. When it comes to the non-physiological jaundice, we mentioned that there are two ways of classifying it based on the type of the elevated bilirubin or the time of onset. And as we'll see in the coming slides, clinically, you'll be combining both of the categories to catch the diagnosis as quickly as possible. And to wrap up, the final and the most important point is that jaundice within the first 24 hours of life is never physiological and requires prompt workup to find the underlying cause. Alright guys, so I'll see you in the next presentation. Hope you learned something.